Thank you very much, Gail, and good morning, everybody. Now, for those of you who were not here last night, we have a few little bits of housekeeping to attend. Are you all shining your light? Please? That means, if you weren't here, Donna, I'm looking at you, that means that you imagine there's a little light on your chest and you need to shine it forward, which means your posture needs to be improved. So also throughout the next hour, I need you to become meerkats. So I expect to see people bobbing up, thank you, throughout this presentation. Thank you, sections setting the scene, to stretch your legs and to adjust your posture and to prevent the squishy gut that we all want to not have. So look, last night was inspirational. I have to say, last night I watched the eclipse of the moon. The moon went red. Thank you, Liz Harford, who texted me to remind me, because I was also fulfilling my obligation of watching the mental health program that they made in Liverpool, which was fabulous. But I did get up at 5:30 this morning, and under the light of the new moon, I went for a walk. So I have started a new leaf. I have my movement green card in my wallet on top of my credit card, as I was instructed to do last night. So I hope that you all were equally motivated. I want to start off by acknowledging the traditional owners of the land that we are on today, our Wiradjuri people, and acknowledge the elders past and present, and in particular those who are present at our meeting today. Just in terms of acknowledgements, I would also like to acknowledge an old friend of mine, Robert Bradley, an LHAC member who has just passed away in the recent days. And Robert was an inspirational man, many of you remember him. And he befriended me many years ago, and he always looked after me, and he always was passionate about his community. So you might just have a minute's silence for Robert. Okay, and now Gail has set the scene with me being our new Chief Executive and your new Chief Executive, and I live to serve. So the theme of today's forum was really timely for me, because have you ever been to those job interviews where they say, what are you going to do in your first 100 days in the job? So I thought Gail might ask me that when I go for my interview, and there were some scary people on the interview panel as well. So I duly prepared my plan for the first 100 days, and they didn't ask me. But it was kind of handy for today, because I had my 100-day plan, and strangely, it fitted into the theme of today's, I've just got to make sure, yep, it's working. The theme of today's forum, which is mind, body and soul. And what I had done when I got my plan together, Gail, was that I had sort of put together what I would do in terms of planning for our future, what are our goals. And as a new Chief Executive, one of the good things to do is to actually get out all the plans. You know those plans, we write lots of them, and they sit on the shelf. But you know what? I actually just read them all, and it was really, really good. The first thing is our board. Our board set a purpose for this district which is better than any I've ever read, and it is to improve and provide the best health outcomes for rural people. So Gail just said, yes, we have a few problems with the money and the bean counters, but in actual fact, if you put improving health outcomes behind every strategy you consider, then the future becomes a whole lot easier to determine. Because sometimes the way our services are configured, historically sometimes, and because we've always done it that way, don't deliver best outcomes for people. And that was one of the things that I've found. I thought about our structures, and that's our body. We've got lots of infrastructure. Again, the board strategic plan talks about better utilising all of our facilities. We have 31 hospitals, 14 outposts. We've got buildings everywhere. And we're building new ones as well. And then our soul. Our soul was the easiest thing to plan for and the hardest. Our soul are you people, they're our communities and our staff. And I totally agree with Gail. Because we have been under financial challenges for the last few years, it's easy just to focus on that. But we have to reward the people who are providing our services and who are still here, loyal and committed to their communities and to their hospital. And if we do not reward our staff and give them a vision about what the future will look like, and it has to be brighter than we are now, then we are never going to move forward. So my talk today really is about mind, body and soul. And just a little bit about me, for those of you who don't know me, and I do know many of you. It's funny looking around the room over the years, I have met some of you in my travels, but I do come from a clinical background. I haven't worked as a clinician for a while, but when I was talking to Pam today, it all came flooding back. I have actually worked in the private sector. I've worked as an educator. I've worked in large Sydney training hospitals for 10 years. And then my husband, I married him, he is a vet. And I'm looking over there at Jenny Wilkinson because her husband's a vet too. And he told me one day we were moving to the country. And I thought, that's good. I actually really like the country. I've never lived there, but I really like it. So we moved to Gundagai. Did you know that? And we lived underneath the vet surgery. And on my first day, I went shopping. I went to the butcher's. There was nothing there, just a man. He said, what do you want? And I said, don't know, what do you got? Because I lived in Balmain. Everything was laid out. I just pointed or I just picked it up. He said, I was so terrified. I did not know the cuts of meat. I didn't know what to ask for. I ended up getting some thin sausages because it was the only thing I knew. And then I tried to pay him. Well, he didn't take money. He didn't even have a cash register. He said, put it on the account. I said, I don't have one. He said, what's your husband's name? I had a different name to my husband. That caused a bit of problems, even though we are married. Anyway, long and short of it was, all over town I got accounts. I wasn't allowed to pay for anything. Everywhere I went, I had to do that. Hello? You know when you're driving, 2 fingers up, Jace? If you didn't say hello, somebody would pick you up. So that was my introduction to the country. We later moved back to Canberra, and I worked in the Canberra system for a very long time as well, in the Canberra Hospital, which is now gone. That's where I discovered my passion of being a midwife. And when Peter told me we were moving to Tumut to set up practice, I went, because I used to do prenatal education in Canberra. That was part of my job. So we moved to Tumut and I got a job. And I'll never forget the first time as a midwife I saw a birth in Tumut. Now, who's here from Tumut now? Narelle Mackenzie. She's a midwife. Narelle, I think you were there, but the first birth I saw in Tumut was the first normal birth I had seen in my life. I had been working as a midwife for 15 years. Because every hospital I'd worked in, big Sydney training hospitals, Canberra Hospital, all intervene in birth and do not let women birth under their own steam. I cried. I was beside myself. I thought I knew everything. I knew nothing. So working in the country gives you a totally different perspective about what life is really like. So I'm going to start off by talking about the mind part of my 90-day plan. And importantly, I started thinking about how siloed our care is that we provide in the country. because there are a lot of other health providers out there. And I had been working on something with Gail and Susan, in fact, around palliative care, and it's really a very inspirational thing. We had had a lot of bad media around palliative care services in this region, and we decided that we would do something about it. If we pieced together all the bits and pieces for palliative care, we could pull together, through a public-private partnership, a really good care for people. We've got a nurse practitioner in palliative care. We've got doctors specialised in palliative care. And so working together, we're actually able to look at how we could improve the care in Wagga Wagga for people who needed palliation. And we've still got a way to go because we have to improve the care that we deliver out in our small towns as well. And that's really important. But we've actually shown that we can do it, but we need to do it in partnership with other people. And the collaboration of the people who came together, the Medicare Local, Calvary Healthcare, Murrumbidgee Local Health District, and the Forest Centre, one of the aged care providers, is aspirational because everybody there wants the same thing. They want to improve palliative care for people in the Wagga region. So it was a starting point, and we have a long way to go now to also build up better services for people in smaller towns. Then Hammond Care came on the scene, and Hammond Care are a group of people who can provide additional support for people who choose to die at home rather than in hospital. And the partnership that we formed around the palliative care unit in Wagga was around giving people some short episodes of care inpatient so they could go home and be comfortable at home with their pain managed. And so Hammond Care provided an additional string to our bow that provided home care packages for people in their final days that can also help to support people and families. Then you added the New South Wales ambulance. So Gail and I were on one of our site visits that she talked about. Actually, we were in Lockhart. And the community nurses told us another piece of information that added to the whole picture, which was that the New South Wales ambulance have a wonderful, and you can see the picture of it there, which is a collaborative care plan. And that's something that also helped in the puzzle. So we've linked all of the pieces together. The ambulance team will also support people who choose to die at home. So that's just one example of how we can actually link our services together, work in partnership. We've got New South Wales Ambulance, Hammond Care, Calvary Healthcare, Medicare Local, Forest Centre, all linked together to help to try and improve services for people who need palliative care. Another project we're working on at the moment is with Charles Sturt University, and this one's been really exciting. We're actually working with a couple of their master's academic students, and a bit of a bonus for me was I got to be an adjunct professor out of it, so that's a new thing I can add to my end of my title now. But it's been quite challenging actually supporting these master's students, but they're working in collaboration with us around understanding private health insurance, and they have brought a whole fresh new light into what we're doing. They did a survey of the managers, by the way. So all the managers who are here, stand up. Take a bow. Because Morris and I, who's our Director of Finance, were thinking, oh, we've got a slightly higher revenue target this year, and oh, we'll just, encourage the managers to try a bit harder. Well, the survey that Charles Sturt University did showed that our managers in Murrumbidgee know more about collecting private health insurance than any other health district. They do it better, and they are doing and achieving right up there at the top of the benchmark. So what we needed to do was actually to focus on some of our visiting medical officers and improve their understanding. So we could have gone off in completely the wrong direction, and those people who have already achieved wonderful things and know all about it, if we'd pushed them a little bit harder, we could have disengaged them. So partnerships often bring fresh eyes to things, and we can learn from partnerships, and I think that's really important. So partnerships link services and bring new ideas, and they help expand our care out a little bit further. The other thing that's really important about Mind is something that has become very important in recent years. Involving patients and their families in the care that we deliver. And there are lots of patient stories out and about at the moment. Part of what we are now doing in Murrumbidgee is every meeting that we have, we start with a patient story, because it's very easy to disengage ourselves from what we're here for. So our nurses and our staff are going around collecting patient stories, and I know that some of the LHACs are doing it too. Are any of you guys collecting patient stories, visiting your patients from the LHACs? Excellent. Yeah. What do you do with your stories? Yep. I find that it is the richest and the most emotive source of information, because unless we listen and actively listen to what our patients are telling us, we don't really know what's going on. And I think that's why Gail and I love doing the site visits, because when we talk with our staff and we meet patients and families, that's how we really know what's going on. You can't really know what's going on sitting in an office, and we have to deeply engage with our families, and we have to provide opportunities for them to be involved in their care. And I know Liz Harford, who's sitting up the back, sent me a photo in an email about something called Reach, which is a very simple program where families can actually contact somebody in their health service if they're worried about their loved one, worried that they're deteriorating and nobody's listening. And I think there's lots of things that we can do to further improve person-centred care. And it is very, very important to me. The other thing that's been really interesting is the way that our services are put together. And I have to say that a lot of it is historical. And Sarah Tobias is sitting up the back there, and she and I have recently engaged in a very painful process but extremely important one, which is the planning for stage 3 for the Wagga redevelopment. And our partners who help us with that, called Health Infrastructure, have said to us that this is the first time in New South Wales they have planned exclusively for primary community health, and a very large one in a large centre. When we started looking at the data, what we found was that we have a lot of patients who are in our acute hospital beds who are actually typed with an avoidable hospitalisation. So they're people who've got things like urinary tract infections, you know, a chronic pulmonary disease, or a cellulitis. And the best health outcomes for those people are with their GP and not in an acute bed for long lengths of stay, because often those people are over 65, and sometimes if we put those people in hospital and don't promptly treat them, they will deteriorate even faster in hospital than they would if they're being cared for by their GP. So we're now embarking on an understanding of what alternative models have we got for those people out in our communities. And we're now thinking, gosh, we're going to really have to look at how we have got those services constructed for what we call ambulatory care. So that's actually acute care in the community. And we have very much focused on providing aged care in the community and wound care in the community, but we do have a lot more work to do in planning for ambulatory care. And it's a really important thing for us in the future, because there are better health outcomes for people who have ambulatory care with those avoidable hospitalisations. And the best thing too, of course, is that it helps control cost. The other thing that we're looking at is how our patients are flowed around the district. At the moment, all roads lead to Griffith and all roads lead to Wagga Wagga. So we're looking at how we might be able to triage patients who need to be transported and who need a hospital bed, and look to where they might best fit, and where we might best be able to move them to and look at providing the appropriate transport. So many of you, and I know West Wyalong here, Pam, I know for years and years when you had only very minimal medical coverage for your hospital, we had a thing called COSOPs where hospitals almost went into a disaster mode when we had no doctor there. But now times have changed. We have technology. We need to work out how we can better link our hospitals together using technology so that patients can actually have assessments without having to be put in an ambulance and sent from West Wyalong all the way to Wagga when they just needed an IV antibiotic. Okay, so if we just move on now, I haven't seen any meerkats, and we're almost halfway through, so I need to see a few bobs. Are you all sitting up, shining your light? Jason, slumping. Okay, we're moving on to the body now, which is why I'm getting you to think about your body. No squishy guts during this topic. There's just a few headings up there that I'm going to touch that fit into this next category. And I didn't, and I won't go into all our capital works programs, but section has got photos which we can put up just prior to morning tea of all of the building that we're doing at the moment. And let me tell you, Bob the Builder used to be my second name in my old job. Donna Hannigan is sitting down there. She's got a completed new hospital and knows the pain that it is to deliver it. We've also finished Lockhart in recent weeks, months, and have opened that. And that was an $8 million refurbishment. So that's been a really wonderful experience for the LHAC at Lockhart. Wagga, as you saw, and I think about 30 of you showed up to the tour, which freaked out our director of the redevelopment. But as you can see, that hospital is leaping out of the ground at Wagga, and it's very exciting because these projects are not bricks and mortar projects. Really, health infrastructure build the buildings, and we have to make sure we've got the clinical space and our doctors and nurses engaged in the floor planning. But what's critical is the change management. And Paddy Tyrrell-Clark is sitting up there at the moment, right in the middle of a change management process with her Hillston redevelopment, because we don't take old practices into new hospitals. We all have to look at what are the new models of care, what are the ways that we're going to operate, how is it going to work, and they're absolutely huge pieces of work, this operational commissioning. So really, I think if you think about capital works projects, whilst you can think about nice shiny new hospitals and just add up the dollars that you can see there, but what it really needs to deliver is better care for our people and new models of care and a change. And it's really important that we update and modernise and provide contemporary models of care. So if we look at Wagga, so we've got almost $3 million there. They're going to provide new angio suites, which is your cardiac catheters. They're going to provide MI, is it? Not medical imaging. What's it called, Donna? God, I've got MRSI on the brain. Sorry. MRI, thank you. Liz Harford is furiously up the back trying to tell me. MRI, which we don't have there at the moment. And there's going to be a medical assessment unit. There's going to be a paediatric outreach unit. There's a whole lot of new models of care that are coming into that hospital. And there'll be a helicopter that lands on the top. So if people actually need to have a cardiac stent, they can land on top of the hospital, go down a lift and be straight in the cath lab and have their catheter put in. Now they've got to go by ambulance, there's time delays, and it's just going to improve health outcomes for our people enormously. So very exciting news. Anybody here from Barham? Yay! Di's there. We've been hanging out, Gail and I, for this announcement. $15 million for a new MPS at Barham, and that's really fantastic news for the Barham community. They have a world of pain in front of them in terms of the planning, but it's for a fantastic purpose and it's really exciting. And some very recent news, which we've just found out, is that we've got some little bits of money to do up our operating theatres in Young and Tumut. which will really help to deliver more of those surgical services in local towns so people don't have to always drive to Wagga all the time. I've talked a little bit about telehealth because it is a particular passion of Gail's and mine. And what we've actually discovered is that we don't need a whole lot of expensive whiz-bang technology. We've actually got within our means an opportunity to use a whole lot of different devices to deliver telehealth. And some of you are nodding, and that's probably because you've always known that. But we already have a very, very well-working mental health video conferencing system, which you all know about. But we can now link together using just computers with cameras on the top and a few over bed cameras, all of our small facilities. And we're going to look at how we can link them into acute hub hospitals. So we're going to make it happen. We've got a bit of a mantra in our team, which is innovation, just do it. And we are just going to get telehealth happening. And we have put on a telehealth project officer who has just been up to Dubbo to have a look at how their telehealth system is configured. Because it isn't actually about the technology, it's actually about who's at the end of the camera. So when you turn it on, there's somebody there, and that we use it all the time. We don't just use it for that one-off emergency, that critical care event when there's, somebody really seriously ill. We use it all the time. It's got to be called providing clinical care, not critical care. We have to turn on that camera constantly, and there needs to be somebody dedicated on the end, and we've got a cunning plan that we know we can make work. So that's coming, and it will take lots of consultation with yourselves around how we do it, but we've certainly well advanced with those plans. On a state level, our Minister for Health, Gillian Skinner, has put a $49 million pot of money aside for rural e-health. And that's with an understanding that whilst we've really adapted our corporate ICT systems really well, we haven't done necessarily the same with our clinical systems. So I'm just about to interview for a project officer for rural e-health, and that's going to bring a package of things our way. So the first thing that's coming is something called HWAN, and basically HWAN are just big pipes of broadband that are going to go to all of your hospitals, and Wagga's going to get two and Griffith's going to get two, so if one breaks the other one still works. And also to places like Murrumbidgee, Tulibuck, they need better broadband as well. So that's happening. In fact, those pipes have all been ordered and they're being shipped from Germany. So that's going to improve our broadband speed and provide a platform for the other things that are coming. And the other things that are coming are electronic medical record for our small sites. So who's here from Corowa? Corowa, you better stand up and take a bow, because you are number one. Thank you, Mark Massey. First site in Murrumbidgee to have EMR2, which is the whole paperless system. So his hospital's going to be paperless. Andrew Dagg sitting over there, you better stand up because you are also part of the wave. So, yep, Corowa's happened, and I think, is Danny happening right now? November. Okay, so in New South Wales, we're the first ones getting EMR2, yay, in our part of the Western world. So I think that's really important, and every hospital will have that very soon. That's quite a big change piece. What do you think about that, nurse managers? How are you going to cope? The other part of the package is community health thing called CHOP, which is community health and outpatient clinic, and it's electronic medical record that actually integrates with the hospital record. So in fact, a patient can be anywhere in Murrumbidgee and we could look up their record. We could see they'd been in community health in Gundagai and now they're in Hillston. And we could read it all, we could see their images, we could see their pathology results, and in fact we could see their images in the state repository if they'd been in a teaching hospital in Sydney. So really, really important stuff for us. This is how we're going to actually work more effectively. It's really big, very important. And the final piece of the puzzle is called Health eNet, which is the opportunity to extract all of those records up for the GP to see as well, and for us to be able to see the GP records. Isn't it crazy? In a small town like Batlow, the doctor would come in and see a patient and not be able to see his records on that patient from his rooms. He may not quite remember what medications that patient's on. So wouldn't it be great if the doctor came into the hospital and could see his records and could see a list of the medications? It seems really simple stuff, you know, but it's not happening. We've got different systems in the community, different systems in the hospital, and different systems in the GP rooms. Health eNet is the thing that's going to pull them all together. And lastly, we've already started, this is a web-based system for managing the use of antibiotics. And again, Murrumbidgee was the only health district around this area that said we wanted this, and our pharmacists were ecstatic. So again, we're leading the way in antibiotic management, which will reduce the number of multi-resistant organisms. Many of you have seen your point of care testing. Point of care testing are devices in your ED. Liz has got one in her ICU, where we can actually test patients for some of those pathology tests in our emergency department and get the results on the spot, and can reduce the need for transport, or alternatively, if we're testing for somebody who's having a heart attack, confirm that they need to be transferred to a specialist centre. So we've got 26 hospitals across our district who have just had this all installed. They're all linked up to the EMR, so those results will go straight into the patient record. So I think using technology is a really important part for us going forward. We have to link our systems together, and we have to be able to see what each other is doing to give better healthcare for people. And the last piece in the puzzle is also hearts. So if somebody comes in with chest pain and they have an ECG, if that person is having a query heart attack, we can actually transmit that ECG, again using the wonderful technology that we have, to a cardiologist to read that immediately and to say whether or not that person is having a heart attack and what to do with them, because we have to bust the clot then and there, and that will improve health outcomes. So all of these things are about improving health outcomes for people, linking them closer to specialist care in the small towns. And in Wagga, they're doing some work also around fractured hips, which is actually about some standardised care to make sure that people have good health outcomes. And also, we're doing some work with people, instead of going straight to hip replacement and knee replacement, we're working with people with osteoarthritis and osteoarthritis, and helping people to have some conservative treatment rather than just go straight to a hip replacement. So you can see there's lots going on in the body, isn't there? We're building things, we're changing our models of care, and all of those projects that I had up there at the end are ones we're doing in partnership with the Agency for Clinical Innovation. So what we're doing is bringing best practice to our country towns, to our country areas, so that we can make sure that we continually improve the health outcomes for our people. And I keep going back. Ah, thank you.
Got a drink now.
Oh, good.
Everybody get up and down.
Up and down, up and down. Hopefully she's not waking you all up. Maybe you need to have a drink too. The water jugs are getting a good workout. Okay, we're on to the last bit, which is our soul, which is you people and our staff. Recently, we got the results of an inpatient survey. So every couple of years, the Bureau of Health Information do a survey of patients. And this year, they have only surveyed Deniliquin, Griffith, Tumut, Wagga and Young. So when you see these results, it is only about patients from those particular hospitals. And Sechin, being a very clever person with her word art, has put together what you can see on the screen there, which is the words most frequently that came up in the feedback section. And these are the best things that people talked about when they were surveyed about their hospital. And you can see there that it's all about the people in the hospital, isn't it? It's all about the nurses and the doctors. And in fact, in our survey, Murrumbidgee did do better than the state on average. And these are the things we did better in, and I'll then tell you the things that we need to improve. So we did better in courtesy in the emergency department, patients feeling involved in discharge, making home arrangements following discharge, and discharge not being delayed. We also had lower waiting times in the emergency department than the rest of the state. And also we had people felt that nurses washed their hands more often than the other people in the state. They also felt that they were well enough to leave when their discharge came around. And here are the things now that we need to look about improving. And we said to our managers, read the feedback in this survey because it's really interesting. It's really interesting looking at what people said. There were traits that were below the state average. One of them was the ability to get appropriate explanations from clinicians about their care and treatment, and a copy of their letter to the general practitioner. So there's something there around how we communicate to our patients and them understanding the care that they're getting, and then making sure that their GP is included so that they don't go home and see the general practitioner who knows nothing about the medications that they've been put on. I think these patient surveys are really important for us because if we're going to change our culture, I mean, we're talking about doing new things, but we also have to do new things with our staff. We've talked about rewarding them. We need to bring them on the journey with us to make sure that they retain the compassion that we heard about yesterday. And one of the biggest things that came up when we unpacked the survey was the word dignity. Because the things that we need to improve the most are the things that I've got on the screen there that came out of the feedback. And these things are all about treating people with dignity. So it's all about how we respond to them and how we communicate with them. And to help you think about that, I'm just going to show you a very short video. There are some very powerful messages there about how patients feel in hospital. So we have sat down to have a look at that patient survey that was recently undertaken, and we crunched all the words together, and what we came up with is the fact that when people are in hospital, they said the nurses and the doctors were great. They loved the nurses and the doctors. They said that their waiting times were good. They said that they needed more information about the care that they were being delivered. But the most and the strongest message they gave us was they wanted to be treated with dignity. And it was a very powerful message that came out of our patient survey, because in actual fact, we probably could have put 10 plaster casts on every bone and limb on their body, and they still would have said the doctors and nurses were great if we'd explained it all to them and treated them with dignity. So it is really, really important. And that last picture, number 5, where that man was treated like a child, how many times do you see that when nurses interact with older people? They shout at them, they call them dull, and they treat them like children. And I think that we need to always consider that. And one of the messages that I'm going to be talking about on our site visit scale is how we can improve how we treat people with more dignity to improve the experience that they get in our hospitals. So for me, it's about, we do all these surveys, but what are we doing with the information that we get back? And I think we need to try and link it with some messages for our nurse managers and our other managers to take back to their staff to make it more meaningful for them. So we also had a survey, coincidentally, of our staff. And this was actually done, this was actually done by the Public Service Commission, and they actually did a survey of all the clusters, as they call them. That's all the public servants, which we all are. And they gave us our results. And once again, I said, well, okay, it's good. Look at this. Our survey measured employee wellbeing, how our staff felt that they were being engaged with the executive, how they felt that their organisational values had been adopted, and their perception of workplace practices. So overall, we did better than the state average, which meant that overall our staff felt in those areas that we had actually provided a better workplace than the average. However, there's a whole lot of things that they told us that we need to focus on. Performance management. Every manager who works looking after a team of people knows that if there's one person not quite pulling their weight and everybody else is doing the heavy lifting, that becomes a bugbear and a source of difficulty in the workplace. Also, access to the right learning and development opportunities. And in the rural areas, that's quite a big challenge for us when people are, at Hillston and Barham and places like Lake Cargelligo. How do we make sure that our staff are linked in to the right opportunities for learning? So one of the things that, again, we're leading the state, the Chief Executive of HETI, which is the Health and Education Training Institute, regularly rings me and says, Jill, because she used to be my old boss, by the way, Jill, you're leading the state. Your nurses and doctors are doing more online training and education than any other LHD. And she rings to tell me that, and she rang to tell me that again the other day. And that's fantastic, because that means that our staff are seizing an opportunity to do online training and learning to keep their competencies up. And that's really important for us in rural areas, and that's one way that we can help improve opportunities for people. Because the board have put in their strategic plans, and you can all see them, they're around the place here, that they want to make Murrumbidgee an employer of choice. And one of the strategies that's worked the best for us in terms of filling our vacancies, which we've done really well over the last few years, is by growing our own. It's been the most successful strategy of all. So instead of bringing people down from city to work in the country, we've actually found that giving people training opportunities and keeping them in the country is our best strategy. And also giving people extra opportunities that they wouldn't get in the city. So you can see there that we had a huge number of midwifery vacancies a few years ago, and it was really quite concerning. Now we've got something called Mid-Start, which is a statewide program that helps registered nurses to do their midwifery qualifications. And we've also got rural midwifery scholarships. And there are many nurse managers here today who have had staff go over to Wagga to train as midwives to go back and work in their smaller hospitals. We've got a wonderful transition from university to being a registered nurse program in Murrumbidgee. You can see the numbers there. They're massive numbers. Our nurses are training new nurses every day. And 80 places in 2014, or 80 applicants in 2014 is really amazing. And to think that we're going to train 62 transition nurses next year. And that's really quite an achievement. That's a big number. And we've trained close to 60 this year. So those are nurses who are out of uni and they're in year one, and they're actually doing a specialised program that's helped supporting them transition into being a registered nurse and taking full responsibility. So that's been an important strategy for us. I want to acknowledge also the talent that we already have in our staff. So this year, Gail was in Sydney, as she mentioned, for the Nursing Midwifery Awards, and these two wonderful people beat every other nurse in the state. And that is extremely, makes me very proud. So we've got Trish Granger from Young, even better, was actually nominated by two consumers, and Norma Smith from Rehabilitation in Wagga won Excellence in Nursing Midwifery. So just because we're from the country doesn't mean to say we can't be the best. And one of the last thing is that we're doing for our staff is we have invested in a position to help keep our staff well. And we have a lovely lady who provides all of our staff with access to information around how to keep well, how to keep safe and how to keep happy. And she's a very proactive person, and no doubt in your LHACs from time to time you'll see programs running around the hospital. We all had pedometers on one month and we were all doing our 10,000 steps, and she has something every month that keeps us all engaged. That's about us investing in our staff. That's about saying to our staff, you're important, and we want to look after you. So I'm just going to finish now with something talking about being proud. We have lots of people in Murrumbidgee who do amazing things every day that you probably never hear about. And this was something that came across my desk just last week. This was one of those transition nurses I was talking about a minute ago. He was working in paediatrics. He just happened to make a video, and our manager of public affairs came and said, can you have a look at this video and see if it's okay for us to release? And when I looked at it, I just thought it was magic. So I'm finishing off sharing what one of our staff has made about children who are needing surgery at Wagga, and it's something for us to all feel proud about. So thanks for your time.
Hi there, my name is Tanner, and these are my parents. We're here on the children's ward at the hospital for my operation. I'm really scared about having an operation, but my mum says that I won't feel a thing because I'll be asleep. All of these nice nurses look like they will take good care of me too. This is going to be my room while I'm going to be at the hospital. Dad has to go to work now. Bye, Dad. The nurse asks me and my mum lots of questions. I wish I had something to eat before my operation though. Dad wouldn't let me have breakfast. He said that I'd be really sick in the operation if I ate. The nurse says that I can have anything I would like after the operation at least. Now the nurse needs to check my vital signs. She puts a peg with a red light on my finger. That checks how fast my heart is beating, which seems very fast. She also wraps a weird cuff around my arm. That blows up like a balloon before letting it go slowly. It feels like my arm is being given a big hug, so it doesn't hurt. The nurse puts a bracelet with my name and birthday on my ankle. She says that I have to wear this so everyone knows who I am. Teddy gets one too so she doesn't get lost. Because I'm having an operation, I also need to wear a special hospital gown. Now that I'm ready for an operation, I get to play with the other kids while I wait. After waiting for a while, a wardsman from the operating rooms comes to pick me up. I get to ride in a bed, which is a lot of fun. Must be what a roller coaster feels like. When I arrive at the operating rooms, I meet a nurse that will be looking after me during the operation, and the anaesthetist who makes sure I stay asleep. Mum gets changed into some funny clothes too, so that she can be there when I go to sleep. The anaesthetist explains to me and my mum that I will fall asleep while breathing through a special mask. He says not to worry because I won't wake up until the operation is all over. He then starts trying different sized masks on me to make sure there's one in my size. Once they've picked the right size mask, the nurses take me into the operating room where they put the mask on and I fall asleep. After the operation, I wake up in a place called recovery. There are nurses that make sure that I am doing okay. The recovery nurse checks my vital signs and gives me medicine through a straw in my arm that was put in during surgery. It feels a bit cold, but it doesn't hurt. It'll get taken out when I'm allowed to go home. The nurse says it's really important to take my medicine, otherwise I could get really sick or sore. Once the nurse is happy that I'm well enough, I can go back to the children's ward and see Mum and Dad. Hopefully I'll get to have something to eat or drink now. The nurse checks my vital signs again before getting me some juice to drink and some ice cream and jelly to eat. Sometimes you can feel sick after the operation, but the nurse says this is normal. I'll have to stay here for a few more hours so the doctors and nurses know that I'm going to be okay. Sometimes you need to stay overnight if you need to be watched a bit more closely. But don't worry, Mum gets to stay as well. When I'm feeling all better, the doctor said I can go home. The straw gets taken out of my arm. It feels just like a band-aid. Then I get an award for being so brave. At last I can go home. Having surgery can be very scary, but hopefully this video makes you feel much better about coming to hospital for your operation. Thanks for watching. Bye!